So following on from Mike's presentation, what I'm going to talk to you about is conservative treatment for FAI syndrome and ask the question, where are we now? But what I'd particularly like to focus on is physiotherapist-led treatment for FAI syndrome and where are we now. So I'm a sports physiotherapist as well as a researcher and still work in clinical practice seeing these patients. So from the presentation that Mike's just given us, and for those who are familiar with the literature, we'll know that much of the knowledge around hip pain is focused on male athletes. But if the typical patient in the community that we see in our clinics who presents with hip pain looks like this, where the Danish hip arthroscopy registry data, which was published earlier this year, showed that in 1,835 patients, 53% of them were female, with a mean age of 38 years, and almost half of those patients who went to surgery with hip pain were aged over 40. And then Mike touched on this North American cohort by Cloisi and colleagues, and in over 1,000 patients, 55% of those patients were female. They were a little bit younger, close to 30 years, and they were slightly overweight. So is the male athlete the right person that we should be thinking about? And when we come to our clinical trial that we're currently conducting, and I had a look at the descriptive characteristics of that cohort, what we found was that 52% of these 60-odd patients were female, with a mean age of 37 years. They were slightly overweight. They had an average pain in the last week of 5 out of 10. Their worst pain was 7 out of 10, and their pain after physical activity was also 7 out of 10. When we looked at the IHOT Sport and the IHOT Social subscales, which is a hip-specific patient-reported outcome measure, for sport they only scored 37 points out of 100, where 100 is the best possible score. And for the social and emotional subscale, they only scored 46 points out of 100. And if our role as physiotherapists is to hopefully prevent these people from undergoing surgery, then I think these are the patients that we should be discussing more than we do now. So I'd like to introduce you to one of my patients who we'll call Miss M. So when Miss M presented for her physiotherapy consult earlier this year, she said that she had pain in her hip for over 12 months. She wanted to be able to walk or train at the gym without suffering for the next month, and she wanted to be able to sit for at least 30 minutes. She'd put on 10 kilograms since the onset of her pain. She said she didn't want to have surgery if she could avoid it, but she was starting to feel that this was her only option. So she's a 37-year-old full-time psychologist, and she's also the mother of 3 school-aged children. She's quite short, a little on the plump side, and she would be considered obese. And so where she started off in the top image, right now she's looking a little bit more like the bottom image. Her pain began in February 2017, so 12 months prior to her physiotherapy assessment, and she'd not been able to exercise for those 12 months because she got pain as soon as she started to walk. This was the first time that she'd had pain. Her average pain in the last week was 6 out of 10, but her worst pain was 8 out of 10. When we asked her what the 3 things that she wanted to achieve from her treatment were, she wanted to be able to walk 6 kilometres most days of the week without getting aching afterwards. She wanted to be able to sit on the train or drive for at least 40 minutes without getting pain. And she wanted to be able to go to the gym and do exercises like squatting and leg presses without suffering for the next few weeks. So Miss M, how do we know that the hip pain is FAIS? And Mike's just given a fantastic summary of the fact that we probably don't really know. But if we take the Warwick Agreement and we look at this pain location, as Mike said, she had that deep-seated anterior groin pain. And we look at the Warwick Agreement, which said that patients to be diagnosed with FAI syndrome needed to have positive imaging findings, the symptoms and the signs that you see in FAI. What we saw in Ms. M was that she had an alpha angle on a Dunn 45 view of 75 degrees, which is considered to be typical of FAI. She had pain on activity, particularly activities that involved flexion and rotation. And she had the typical physical impairments that we see in FAI syndrome, which we'll discuss in more detail. So moving away from Miss M, now let's look at the impact of FAI on patients who are suffering. And Rinte Agricola's work has shown that people who have CAM morphology do have an association with an increased risk of hip osteoarthritis and hip joint replacement in later life. When we look at patient-reported outcomes across a number of different stages in people with FAI, what we can see is the dark blue line represents controls who don't have the syndrome. This bar here represents people who are waiting for surgery. These are people immediately after surgery. This is 2 years after surgery, and this is 3 years after surgery. And what we can see for both pain, ADL, and quality of life in particular is that these patients are significantly impaired when we compare them to where their aged matched peers sit. And if we plot Miss M on this chart, these were her scores. So she was significantly impaired, and in all the criteria she was worse than what we typically see in the literature. So does it matter? I think it does matter for those who are suffering. So while most people who have CAM morphology don't go on to develop the symptoms associated with FAI, for those that do, so people like Ms M, the impact can be enormous. We saw on that previous graph that they have quality of life scores that are similar to people who have hip osteoarthritis. And these are usually young and middle-aged people who have a high level of family and work and social and sporting commitments. Like Ms M, they're unable to exercise, so this has large consequences for their general health. And they do seem to be at an increased risk of developing end-stage hip osteoarthritis and undergoing hip replacement in later life. So I think we can probably say that Miss M had what we would consider to be severe FAI. Her scores and her hip range and strength were similar to those that we see in people with hip osteoarthritis. She also had significant night pain, but I think most importantly, and Mike touched on the mental health component, she had a fear of the impact of her condition on her ability to exercise and maintain a healthy weight, and as a woman in her 30s, being overweight was something that she didn't like. She was also frightened of never being able to exercise unless she had surgery to fix her problem. So what are our options in managing FAIS? Mike touched on surgical treatment, and there have been 2 recently published RCTs. The Griffin RCT showed that the incremental cost of hip arthroscopy compared to a physiotherapist-led intervention was 10 times that of the intervention. So the physiotherapy intervention was actually more cost-effective than the surgery. And Mike also mentioned the Roan study, which showed that there is an increase in comorbidities following hip arthroscopy. So mental health conditions increased by 84%, chronic pain increased by 166%, sleep disorders increased by 111%, and systemic arthropathies increased by 132%. So given that surgery perhaps isn't the magic bullet that we've been led to believe it is, we really need to develop high quality non-surgical treatments for these patients. So what is the current evidence for non-surgical treatment of FAIS? So what I'd like to do is just consider some potential treatment targets using a hypothetical model. We've heard a lot about loads today. If we think about extrinsic factors that can affect the loading within the hip joint, this can include things like the type of activity, the amount of activity, and someone's body mass. But intrinsic factors can also impact on loading, and this includes things like the morphology that we've just heard Mike talk about. But it can also be things like how strong someone is and how well they can move, how well they walk and they run. And these things are influenced by someone's age and their sex. Now, loading is a really, really good thing. And we need loading within a joint to create the reversible joint changes that maintain a strong, healthy, robust joint. But for some reason in some people, maybe the loading leads to irreversible changes that put people in the position where they start to develop pain and they have reduced function. And Mick touched really nicely on the complexity that we're starting to see when we look at factors that can cause disease or factors that are associated with disease. And what I'd like to say is that for those of us who are physical or physiotherapists in the room, we actually have the capacity to influence a lot of these factors. So maybe as physiotherapy treatment providers, we can actually have an impact on these patients. So we've recently conducted a systematic review to look at the efficacy of physiotherapy interventions on hip pain. And this is unpublished at the moment, but the aim of that was to look at the effectiveness of different physiotherapy-led interventions in improving pain and function in young and middle-aged adults with hip pain. So in our systematic review from the 1,750 studies that were retrieved in our search, we were able to include 13 studies. This included 9 RCTs, of which 7 out of the 9 were pilot RCTs, and 4 case series. So what I'm going to do now is just present the data from the 6 RCTs where we had enough data to actually calculate effect sizes. So just to orientate you to the chart, the line in the middle here represents no differences between the physiotherapy-led intervention and the control intervention. Everything on this side of the line says that the control intervention did better than the physio intervention, and everything on this side of the line shows that the physio intervention did better than the control intervention. These little blue lines represent the 95% confidence intervals, and if those lines cross the 0, it means that the difference was not significant between the 2 groups. So neither group did any better than the others. So the first 2 studies have been grouped here where they were physiotherapy interventions. So the first study was a study where they compared a functional retraining and hip muscle strength intervention for 1 hour once a week for 6 weeks to no treatment. And the second study here again had an approximately 6-week intervention where patients either received manual therapy, supervised exercise, advice and home exercise. The control group was just the advice and home exercise again for 6 weeks. These 2 studies here had an intervention that was a much longer intervention where the intervention was more complex, so it included muscle strength, manual therapy, return to sport training and functional retraining. And the final 2 studies are actually the clinical trials that compared hip arthroscopy to physiotherapy. But what we've actually done is we've flipped it. So we've made the hip arthroscopy the control and the physiotherapy treatment the intervention that we're interested in. And so what you can see is the results are quite mixed and they don't always favour the physiotherapy treatment. So in summary, with the 6-week intervention, there was no positive effect or only a very small positive effect comparing the supervised physiotherapy to either the control intervention or the home exercise program. For the 3-month interventions, there did seem to be larger effects. So there were larger positive effects on hip pain and quality of life, favouring the targeted progressive strengthening programs. And in the surgical studies, it was interesting in that at the 6, 12 and 24-month follow-up, there were either negative, no or very small effects on hip pain and function comparing the physiotherapy-based exercise programs to the hip arthroscopy surgery. It's really important to note that the first 2 groups of studies were only pilot RCT, so these studies were not powered to actually find a between group difference. So if we then go to just the physiotherapy-led interventions and what was the improvement from baseline to follow-up in the physiotherapy groups in the same studies. And again, we have the same studies grouped in the same way. Our 0 line is actually here, so everything on this side of the line means that the group who had physiotherapy treatment improved from baseline to follow-up. And again, if these lines cross the 95% confidence interval, it means that the change from baseline to follow-up was not significant. And what we can see here is that with the 6-week interventions, there was a small positive effect for hip pain and function for a supervised exercise-based physiotherapy-led intervention. But at 3 months, the effect sizes again appeared to be larger for hip pain and quality of life for a targeted progressive hip strengthening program. And in the surgical studies, the physiotherapy-led interventions in the surgical studies, there were small to moderate effects on hip pain and function for both the 6-week standardised exercise program and the personalised hip therapy program. But again, remembering that these studies were pilot RCTs that weren't powered to find the change from baseline to follow-up. So what this tells us is right now we don't have any full-scale placebo-controlled clinical trials that provide evidence to support the non-surgical management for FAI syndrome. The best preliminary results in pilot studies seem to be strength-based programs that are at least 3 months in duration. But I think it's important that we don't just walk away from here thinking there's nothing we can do for these patients. Because what we can do, if we think back to that hypothetical model with all the different things that can influence joint load, maybe if we target their known impairments, particularly the impairments that we know are associated with outcomes, we might be able to effectively treat these patients. So what are the characteristic modifiable impairments that we see in FAI syndrome in a patient like Miss M? And there have been a number of studies that have looked at impairments. And just to summarise those studies for you, what we know is that hip muscle strength in all planes of motion and single leg dynamic balance are reduced in people with FAI compared to healthy controls. It seems as though better hip flexion range of motion and better adduction strength is associated with better quality of life. People with FAI syndrome on one side are actually impaired on both sides in their functional performance and their single leg balance. Those who are stronger in their abductors and adductors seem to have better functional performance, and those who have better functional performance seem to have less pain and better quality of life. And if we look at biomechanics in people with FAI seem to have a reduced hip extension angle when they walk. They have changes in their proximal biomechanics in their trunk and pelvis in a step-up task, and they seem to have an increased adduction movement when they do a single leg squat task. So taking all of this knowledge together and packing it up for clinicians to be able to walk out today with something that they can use in their practice, what I'd like to do now is suggest what a physiotherapy-led intervention for people with FAI should include. So if our goal of treatment is to optimise that hip joint loading, allow these patients to return to play and return to performance and target their known impairments, these are the things that we should be including. So we should be looking at hip muscle strength, trunk strength, functional plyometric and balance retraining, movement retraining, cardiovascular loading, and education, counselling and shared decision making. And so now what I'd like to do is discuss each of those in detail. So let's consider hip muscle strength first. So just to summarise what we know about hip muscle strength, it appears that hip adduction strength is very important for all patients regardless of their sex and regardless of their pathology. Abduction is also important for both men and women, but it seems to be particularly important for those who have more severe pathology. Flexion strength and extension strength are important, but they're particularly important in women who have more advanced pathology. Now, I think as physiotherapy, exercise-based treatment providers, it's really important that we think about our strength and conditioning principles. And I think one of our failures as a profession is that up until now, we've been really frightened to load these patients up to actually get a proper strength trained. So I think it's important that we think about the number of reps and sets that we're giving these patients, the rest between their reps and sets, the load that we applied and the time that they spend under tension. We need to start them in progressive strengthening programs that start with lower load, safe positions and progress them slowly to high load, more challenging positions. It's also really important that we tell these patients that they will have some pain when they're exercising and it's actually okay to exercise with pain. So we let them progress when their pain is acceptable to them and when they have a moderate perceived exertion. So here's an example of a progressive hip adduction strengthening program, starting from an early stage. So we have our patient here who is in a very comfortable, safe position. We can load him up with a weight on his foot, progressing into an upright position with heavy TheraBand or pulley-based weights if you've got access to a gym. And ultimately we can progress into the Copenhagen side plank adduction exercise, which I know we're going to hear a lot more about with Per and Christian here. Again, an example of hip abduction strength where we start someone in the early stage in a safe, low load position, progressing in them to mid-stage and more advanced stage hip abductor strengthening. Hip extension strength, starting them in the early stage, progressing them to mid-stage and then more advanced stage exercises. What I'd like to add here is we haven't included weights here, but what I will often do is get someone doing a hip thrust where they may have 20 or 30 kilos on their pelvis doing that exercise. Again, the loading here, we want really heavy TheraBand, so we don't want the light, flimsy TheraBand, or if we have access to a pulley-based system in the gym, we should be using that. And tasks like a single leg deadlift with heavy weights, as heavy as the patient can tolerate. So if we're trying to get a strength effect, we can dose them to be able to do 3 to 4 sets 8 to 10 repetitions, where by the time they get to repetition 8 or 9 or 10, they're really struggling. That weight's really heavy for them. That's what we need to do to actually challenge and progress these patients. So what about trunk strength? Tasks like the side plank task in patients where they haven't got a shoulder problem can be really, really appropriate. And with trunk strength, it's really important that we retrain both sides, because we found that these patients are weak on both sides of their trunk when they had pain on one side. It's important in these patients to watch over activity in their hip flexors, and I think with trunk strength, maybe we need to have our focus a little bit more on an endurance-based program. When we look at function and balance, again, we can start in early stage double leg squat exercises with heavy load, progressing to single leg tasks, and ultimately progressing to high level single leg stepping up tasks. And again, we can add weight to all of these exercises. With all of our functional retraining, again, it needs to be on both sides, because these people are impaired on both sides. It needs to be specific to their sport, with a focus on both strength and endurance, and restore their full load requirements. Plyometrics is something I think that we're often afraid to give these patients, but if they want to return to any sort of physical activity or sport, we need to build that resilience into their hip and into their system to be able to cope with plyometrics. And so again, we can start in a safe, early stage double leg task, progressing to single leg tasks, and then ultimately adding quite a lot of complexity to the single leg task with direction change and speed change and variations such as that. I only want to touch briefly on movement retraining, because Cara Lewis is going to give you a fantastic presentation tomorrow on biomechanics and movement retraining in people with hip pain. But I'd like you to think about it. And when we look at gait retraining, load tolerance is talked about, load management is talked about, and biomechanics is also discussed. And if we look at some of the specific movement strategies that we should be doing with these patients, we need to look at how they move in gait. And gait is not just walking, it's also running. And we can consider variables such as step length, step rate, the amount of hip adduction and internal rotation, the trunk and pelvic position in the frontal and sagittal plane. And we can also look at external factors such as hills that may increase the hip flexion requirements in these patients. But we also need to look at movement in other functional tasks. And we need to look at how someone moves in single leg tasks, how much adduction and internal rotation they have, what their trunk and pelvic position is in both the frontal and sagittal plane, and consider distal factors such as ankle dorsiflexion range and calf strength. What about cardiovascular loading, fitness programs? I saw on the excellent resource that Twitter is, that the American physical activity guidelines have just been released, and they're the same as our Australian guidelines, where people generally should be doing 300 minutes of moderate physical activity a week, or 150 minutes of vigorous physical activity a week, and 2 strength-based sessions. So how can we build this into our patients? So it's important that we do a progressive cardiovascular loading program, so we don't have any of those acute spikes that we've heard a lot about already this morning. We can start with low impact, high intensity activities such as swimming, and we can finish with running and direction change and speed tasks as well, if it's appropriate for that patient. We can progress things like the duration of their cardiovascular loading, the intensity, the amount of impact, the complexity of the task, sport-specific loading, and we can tailor it to suit their preferences. So things like the weather, equipment, and I think most importantly, what the patient enjoys and what their ultimate goals are. And I think it's very important that we progress them when they have an acceptable level of pain. Don't tell your patients they have to be pain-free before they can exercise, because no one will be pain-free. We've seen their outcomes. These patients have pain. But let them know that as long as their pain's acceptable, it's probably safe for them to continue to exercise and to progress their exercise. By taking them up to their threshold, that's the only way we'll actually challenge these patients to improve. And finally, education. What should we be telling these patients? Mike gave a great summary on people's expectations after surgery and how disappointed they often are. So what should we tell these patients? We need to tell them that they have to maintain that cardiovascular load throughout their rehab program. They don't completely rest. There will be something that they can do. We also need to tell them that it's totally normal to have flare-ups of symptoms. They won't be pain-free when they exercise. So we reduce the fear in those patients, and we reduce that catastrophization that, oh my goodness, I've got pain, my hip joint must be falling apart. So we have to really calm them down. We also need to build in a maintenance program that includes strength, balance and neuromotor control as part of their lifestyle. So this becomes part of that 300 minutes of moderate physical activity and 2 strength-based sessions a week should incorporate these elements that we've just talked about. This is just my own clinical opinion, but I find that with these patients it seems to be an accumulation of time in the impingement position that causes their pain. So if you reduce the amount of time over a 24-hour period that they spend sitting at work, bending down to pick up their kids, driving the car, they might be able to spend more time in the impingement position in their sporting activities that they really enjoy. And I think really importantly, setting that expectation right. Yes, you will improve with treatment, but you're probably not going to be the same as your age-matched peer who has never had a hip problem, and that's actually okay. You can live with that and manage that. Christian Thorberg published a great paper in JOSPT earlier this year, and one of the things that he suggested was using that traffic light acceptable levels of pain to manage their pain. And we've talked about that already, but I think that for all of our patients with musculoskeletal pain, this is a really, really nice system that you can use. So coming back to Miss M, we developed what we thought was a fantastic rehab program. But I think the most important thing was that she needed to buy into the program. If she didn't buy into the program, she wasn't going to do the program. We told her at the start that she had to dedicate 6 hours a week to this program. It wasn't a quick fix, it was actually up to her, and she needed to work hard for it to work. We also told her of the evidence and our rationale for the rehab program so that she would buy in and really be committed to the program. So don't be frightened to share the evidence with your patients. We also, right at the start of her treatment, provided her with a clear, structured timeline of the whole program. She was a busy lady. She was a psychologist. She worked full-time. She had 3 kids. We needed to help her schedule in her rehab into her whole life. And what about return to play? Well, if we think about the timeline of return to play planning, from the onset of pain injury to return to play, Miss M was there for the whole process, and she wanted to get from the picture on the left to the picture on the right. As her therapist, we should be planning for this point at her initial assessment and be with her all the way through to the point where she returns to that point. And we can use shared decision making and frameworks like the START framework where the evidence is weighed up against her own individual preferences. We don't have any published return to play criteria yet for FAI syndrome, but we can use things like hip and trunk strength 90% of the opposite side. We can use functional task performance 90% of the opposite side. We can say to them they need to be able to train for 2 weeks with that pain being acceptable for them to be able to start to look at full return to play. There's some emerging evidence using the psychological readiness questionnaire, the HIP Return to Sport Index, and I think Tobias Warner has a poster on this, so I'd encourage you to go and look at that. We can use subscales like the physical activity and social subscale of the IHOT 33, but I think most importantly, our patients like Miss M need to be confident, want to return to play and feel ready to return to play. So our take-home message is that physio treatment doesn't have full-scale level 1 placebo-controlled RCT evidence yet, but we can follow an impairment-based model where we target these impairments. So finally, what happened to Miss M? Well, she underwent 3 months of treatment where she had one-on-one physiotherapy, in-rooms treatment, weekly supervised gym sessions, and also unsupervised gym sessions where we targeted all of those elements that we've just discussed. So remembering this is where she was, this is where she finished after the intervention. So her Hagos pain score went up by 35 points, her ADL score went up by 25 points, and her quality of life score went up by 20 points. And we can see it's only one case, but we can see we do have the potential to return these patients to where they would be, or even better than where they would be after surgery. What about her 3 goals? Well, she felt very likely at the end of her treatment to be able to walk. She felt very likely to be able to sit on the train, and somewhat likely to be able to complete her gym workouts as she wanted to. So last slide. Does FAI matter? Yes, it does. For people who are affected, it has an enormous effect on their sport, activity, quality of life, and they do seem to be at increased risk for hip joint disease down the track. We can treat it surgically and non-surgically, but surgery at the moment doesn't appear to be cost effective and does have risk of comorbidities. But our best practice physiotherapy-led treatment should target known impairments, optimise joint loads to try and improve outcomes in these patients. Thanks very much for your time. Questions?